Hi, and welcome to this week's HSJ Health Check Podcast. As regular listeners will know, each week we explain and debate the biggest health policy news stories with a cast of HSJ expert journalists. I'm your host, Annabelle Collins, and I'm here this week with Bureau Chief James Illman and correspondent Matt Discombe. This week, HSJ has published a wide-ranging interview with the Care Quality Commission's Chief Executive, Ian Trenholm, in which he set out the approach of the regulator could be permanently changed in the aftermath of the COVID peak. And so we're looking at a broad theme of things that perhaps won't be going back to normal as we enter the recovery phase of COVID. So alongside this, we also publish details of major changes to services that also won't be reverting anytime soon. So firstly, we're going to hear from Matt. Matt, you did the interview with Ian Trenholm. But before we dig into the detail of what is going to be happening with the CQC in coming months, could you briefly recap for listeners what happened at the beginning of the pandemic?
Yes, of course. So, as readers will know, the CQC was under a fair bit of pressure at the start of March, at least, to suspend routine inspections amid the COVID-19 outbreak and the kind of pressures and a panic which was setting in there. And in March, I think it was in the middle of March that CQC took the decision to suspend routine inspections, but to keep monitoring providers in other ways, and there's always that possibility of and in actuality they did inspect a number of inspectors where there was key safety risk concerns. During the pandemic, there was a total of 11 organisations which support older people and people with learning disabilities, mental health support needs, who were threatening a legal challenge to that, citing a number of safeguarding concerns. That seems to have been allayed by the CQC, but in July, Matt Hancock, the Health Secretary, launched a call for evidence among NHS staff and healthcare staff, looking for ways to, in his words, bust bureaucracy, which put a kind of key pressure on the CQC not to just revert back to the way they did inspections, perhaps as they did before. So in our interview last week, Ian Trenholm spelled out the transitional approach it's going to be taking to regulating services in the winter, starting from next month, and also spoke about the long-term plan after March, how it intends to regulate services after that. And I think the key message is that he doesn't see inspections going back to or regulation in general going back to business as usual, either during winter or afterwards as well. So to take the transitional approach for winter to start with, the first thing to say is it's going to be widening its scope for on-site inspections, whereas before, as I've just said, they reserved the right to inspect services where there were suspected risks to patients. It's now the CQC is now talking about visiting services where improvements are needed or suspected to be needed, and even for services where the CQC is going to inspect in person. He's talking about a more streamlined way of inspecting and visiting services. So he's talking about in our interview about not placing a burden on the NHS at a time where it's going to be obviously very busy during winter.
I think, Matt, sorry to cut in, but the use of streamlined there is quite interesting. Kind of what does he mean by that? Does that mean fewer inspections? Does that mean faster inspections?
He's talking about an unloading of the kind of admin pressures on providers which would have existed before. So a lot of the data and the information which they would have requested of providers prior to an inspection is now going to be done, hopefully, in his case, by the CQC through new technologies and gathering new ways of gathering that data beforehand, working with NHS Digital and NHS England and Improvement. But he said there's still a balance to be struck in terms of giving the public assurance that the services are going to be safe. In terms of the inspections themselves, they're going to be focusing, in his words, on safety, leadership, and access. And there's going to be less emphasis on the key questions around effectiveness and responsiveness. Although he does stress that all 5 of the key questions are going to be are still going to be asked of providers. This is going to be a kind of shift in focus. And he's also talked about wanting to evolve away from a timetable of inspections.
Yes, I was just going to ask you about that. It sounds that's really interesting. It's it'd be interesting to see how kind of the new data they're collecting will kind of inform kind of the new inspection regime. Just wondering whether he kind of expanded at all on wanting to move away from kind of a timetable. So, trusts expect an inspection on a certain service every so often, and they know it's coming. Will this make it kind of more surprising for providers?
Well, I think we didn't ask him that question, but I'm sure if he was here, he'd say there'll be open communication between providers, and it wouldn't be a complete shock. I mean, a couple of things just to say on that. First of all, he's talking about a intelligence-led approach to prioritizing inspections. So, rather than maybe acting towards a timetable, they'll be inspecting more or focusing on inspecting more services which would, benefit from that or would need that oversight rather than just kind of adhering to a timetable. That said, he was at pains to emphasise that doesn't mean if you're rated outstanding as a provider, you're going to go for years on end without being inspected. There will still be that kind of regular inspection regime, but it's just the way it's going to be focused. It's going to be different.
Perhaps another thing that sort of jumped out, I think, kind of links to that quite nicely, is kind of technology and how that is going to be playing a bigger role in how the CQC operates. And that seems like something that kind of COVID accelerated that. Maybe, I don't know if you'd agree with me, but it kind of accelerated how that is used in inspections. And I don't know whether you'd be able to kind of touch on a few things he said about that in your interview.
Yeah, sure. So he's talking about during the pandemic, the CQC employed a lot of new technologies to source data at scale from partners such as NHS Digital and NHSE. For one example, is the CQC has been able to remotely access patient records as part of their emergency support framework, just to assess the risks faced by providers. Since March, basically. So they're talking about having new ways of gathering this sort of data to identify particular outliers. For example, in new COVID deaths, for example, they're talking about having enhanced data sets, live data sets, looking at where the outliers are and cross-checking it with the experience of their inspectors, for example, on the ground, and talking to providers, and just having that, just using that technology to and that data to just prioritize services kind of a bit more based on risk rather than just a kind of strict and set timetable, if that makes sense.
Yeah, Matt, sorry, I just cut in at this point. What's the general response been from trusts on all this, as they're going to have to be dealing with the new regime?
Sure. So NHS Confederation have come out about the transitional approach during winter. and they have basically said that they want all routine inspections to be suspended throughout winter. I mean, that they come up with a number of reasons for that. Firstly, obviously, because they've got COVID and winter pressures to deal with, to focus on treatment backlogs, and they've also mentioned to deal with the mental health of exhausted staff as well. Now, in routine inspections is NHS Confederation's words, not mine. The CQC have been a pain to impress the words that it's not going to be routine as in business as usual inspections. It's just going to be more inspections during winter. But still, that's a detailed point of detail, really. So Danny Mortimer, the deputy chief executive of NHS Confederation, has written to Matt Hancock, and he's just said there's just too much duplication in regulation and performance management currently. He says it's disproportionate, it stifles innovation, it provides false reassurance, and hinders and not aids effective and safe services. So there's a clear indication about where they want where they want regulation to go in the long term, to be a lot less burdensome, which I suppose up to a point CQC will go along with, but they do seem at odds with the plan for winter.
Thank you, Matt. And I was just wondering, because obviously you cover patient safety as well for HSJ, and obviously kind of safety was one of the key areas that Ian Trenholm kind of highlighted to you. I'm just wondering whether any and no worries if not, but if any kind of concerns have been raised about kind of impact on patient safety of kind of the inspection regime is kind of quite data driven, perhaps more so in the past. Just wondering whether there's been kind of any kind of comments on that.
Sure. Well, I'm looking. I mean, I speak to people in my patch and throughout the country who have told me about their wish for CQC inspections be a bit more proportionate and a lot less burdensome. And that was before the interview, so there's nothing particularly new there. But if I'm looking at some of the comments we've had on Ian Trenholm's interview, there seems to be a bit of a mixed bag from leaders, really. I mean, what some are saying is it's a step in the right direction. They're going to lessen the disruption caused by inspections. I mean, I've heard from sources that some inspections could take trusts a month's worth of time to prepare, and then to have the on-site work, and then all the data collection they have to do, which is obviously a lot of work in very testing times. So there is there are some people who are saying that it's a step in the right direction not to have such burdensome regulation, but you would expect that there are some on the other side of that who are saying that inspections do need credibility. They need to be more robust and not less. That's their words, not mine. And there's a few concerns raised about what Intel-led inspections will really mean. So there, I wouldn't say there's a particular consensus, but I'm sure if you speak to a lot of providers, they would say that regulation does need to change and become a bit less burdensome, if that makes sense.
Absolutely, thank you, Matt. And I think it'll be a really interesting few months to follow kind of how this new regime works out in practice. And I think as I said at the beginning of the podcast, we're also going to be talking about significant service changes around the NHS in England, and I think now's a good time to move on to that. So we've often used the phrase kind of COVID as a bit of a catalyst for change, and we've kind of got into how it's going to be changing regulation. But I'm hoping now, James, you can kind of take us over kind of some of the main things that are happening in terms of service changes and how COVID is perhaps going to result in some things not going back to normal.
Sure. So yeah, as you were saying, COVID, we've already know that it's really changing the way the NHS feels. Hospitals look very different now, especially the need for kind of separate parts to be hived off as COVID and non-COVID areas. And one of the really kind of obvious changes that has been very clear has been the huge increase in kind of virtual appointments for outpatients and in primary care. Now, this was a direction the NHS was heading in pre-COVID, but the pandemic has really accelerated the pace quite remarkably, and much of the change people would have dismissed as not possible pre-COVID, but now it's very much changed the realms of expectation, which is a good thing. We've also seen and are seeing a lot of significant service reconfigurations made under what are so-called emergency measures, which means they don't require the same kind of public consultation, don't require any public consultation that a permanent change would need. And this is because, broadly speaking, they're supposed to be temporary changes to react to what is an obvious emergency. And we published a very interesting analysis this week by our reporter Alison Moore, which revealed the most significant configurations which have been rolled out under these kind of emergency measures terms since the outbreak in March. So, there's I'll just give a few examples to give a flavour of the type of changes that I'm talking about. We've had Cheltenham A&E, which was consultant-led and during the day, but nurse-led at night. That's one of several A&Es that have been temporarily downgraded. Other ones in that category would be Chorley and Grantham. Now, downgrades have been in the process for a number of years there, mainly due to kind of struggling to keep staff ratios at a safe level. But again, it looks like the pandemic has been a catalyst to speed up that process. It's also worth noting that a lot of these permanent downgrades of any departments, including at Grantham and Western as well, began as temporary measures and then eventually became permanent. So there's other examples have been stroke reconfigurations in East Kent. They've centralised a load of services, and also midwife-led units. We've seen quite a lot of temporary closures of them in Lichfield and Stafford. And we've also seen centralisation of interventional cardiology services down in East Sussex, where they've all been centralised at Eastbourne District General Hospital. So, and we also know that some really serious changes are coming down the track as the system prepares for winter. Perhaps one of the most visible ones, which there's trials going on at the moment, but is soon going to become rolled out in a far wider way if NHS England presses ahead with the plans as they are at the moment, which is Call Before You Walk, where patients that would usually have been able just to walk into an A&E will actually have to call and book a slot first, and that is going to be a huge change for patients in the way that they interact with urgent care services.
No, absolutely. I was kind of agreeing with you on that point. It's just such a massive culture change for patients to not just turn up at A&E. I think as you were saying, it's kind of the expectation that people have the NHS is going to massively change. And you mentioned sort of, I think when we're talking about service reconfiguration and A&E closures, I think it's a very emotive subject.
Yeah, definitely.
And I think in HSJ, we're very, very frequently kind of contacted by local campaigning groups who are really concerned about service reconfiguration. And sometimes I think there's a good reason for being concerned, particularly if it means, you're going to have to drive 30 miles further to get to your nearest, hospital that provides a stroke service, for example. But just kind of be interested to hear your take on that. Do you think sometimes those kind of campaigns, and also when MPs get involved, can they perhaps be counterproductive in kind of creating a safer NHS service?
Yeah, I mean, it cuts both ways. But the Helen Buckingham, the from the Nuffield Trust did eloquently explained a lot of the issue and the nuance in this debate, whereby she rightly points out that fear of loss often lies at the heart of public opposition to change, and it's likely that fear will only be exacerbated by the pandemic. And I think when people don't know what's going on, they are suspicious of change. So this whole issue of making a load of changes without consulting people, it's going to make people very suspicious. Whether the changes are a clinical benefit or not, people are going to be very skeptical about them. So I think the public have been incredibly tolerant of service changes during COVID so far, and sort of rightly full of adulation for frontline staff. But the general perception is that there's an implicit social contract under which patients tolerate change in the short term, but with the expectation that things will at some point at least go back to the way they were, or at least the good bits will come back again. And that is maybe a false expectation, really, because the NHS is in a bit of a bind where it needs to make significant changes in an incredibly challenging environment and at an incredible pace in order to protect patients and staff from COVID. But if they exclude patients and clinicians from conversations about all these changes, as has happened many times in the past, then we could see patients' goodwill really starting to run out. I mean, one concern I would have is that could happen this winter. We're seeing, the waiting list is mushrooming. I mean, NHS Confed predicted back in June that that it could hit 10 million by Christmas, and it was 4 million before, 4.2 million pre-COVID. So that's like more than doubling of the waiting list. And within that, you've got the shocking numbers of people who have waited over a year for treatment. So this figure just blows my mind a bit. There were around 1,600 52-week breaches pre-COVID. By June, that had risen to over 50,000. I mean, that's just remarkable. Really bad news. And then the cancer care backlog as well is only last week the Prime Minister was being warned that could cost 30,000 lives. And as these really tragic events unfold, people are going to start asking, well, where was the NHS for me? And if people haven't been consulted about changes to their services, politically it becomes very, very difficult.
Absolutely. And I was just thinking, I don't know if this is too much of a stretch, but there's been a lot of talk from the Health Secretary, particularly around kind of cutting bureaucracy. But if there are going to be a lot of service changes going on around the country, surely that there will be a need for numerous public consultations that we all know can be quite lengthy, kind of a bit of an administrative burden. Also, issues around social distancing and holding public events. Often there are quite a few public events for people to kind of turn up and air their opinions. Just kind of wondering whether this could actually turn out to be a really complicated thing.
It's precisely that. It's going to be incredibly complicated. And the problem is with these debates is that often they're boiled down to this is a good thing, or this is the NHS being cut. And actually the clinical outcomes, which surely should be right at the top of the pyramid when considering whether to change services or not, becomes a bit lost in a kind of political fight between those who believe that the government is just cutting the NHS back and those that believe that, reform is needed and we're not providing services in the most efficient ways. And so, for example, a local MP, if there is a downgrade proposed to their local A&E, it is very rare that they will actually look at it in the round and say, well, what are the clinical benefits? It does happen from time to time, but generally speaking, you have a downgrade of your A&E on your patch and you are looking at losing your seat. So there's been a great resilience from local politicians and councils as well, generally, about reconfigurations, even if overall the clinical benefits are in favour of a reconfiguration. The politics becomes very tricky and a real roadblock. And as you say as well, how do you consult in this time of social distancing and events and so and so. I mean, I would say that we, as a society, we've all moved online now. So I'm sure it would not be on the kind of the technology, if the will is there, to do these kind of things in a more in a digital way. We're recording this on Teams at the moment. Maybe it could be a big Zoom thing or something. But certainly, yeah, I understand why patient groups and campaigners are very suspicious about changes, especially when they're done at pace and without involving them. I mean, straight away you can see why that is going to provoke anxiety. And as Helen pointed out in her piece, that is only going to be exacerbated by the pandemic, which has just raised anxiety levels in general. And if you hear that services, your local NHS services, are going to be cut back at this time, well, understandably, you're going to be probably in the negative camp, needed to be talked over to the positive camp rather than vice versa.
Absolutely, and I think some trusts will certainly be kind of perhaps viewing this as an opportunity, as you said, to kind of make things more efficient perhaps, but then others I think are still waiting to hear from NHS England, waiting for communication as to what's happening to services. And I think a lot of uncertainty at the moment. And just before we close the podcast today, I just wanted to jump back to Matt actually, and that was a really fantastic kind of overview, James, but just on you mentioned particularly Cheltenham. And I just thought might be quite useful just to kind of bit of a case study, really, kind of what on the ground does this actually mean when we're talking about kind of closing a local A&E department. Matt, this is something that you've been looking at for a little while, am I right?
Yes. Firstly, in my current role at HSJ, but also back in Gloucestershire, where I used to be a local reporter there and covered health. So yeah, this saga about Cheltenham A&E downgrading has been going on for some time. I mean, it was in 2013 that the trust decided to downgrade it, and basically what it meant was it went from a consultant service 24/7 to it was to be a nurse-led minor injury service between 8 p.m. and 8 a.m. every day, whereas a full A&E service throughout the other hours has remained since then. But that was until June this year, when the department was downgraded to a minor injuries unit 24/7. No, sorry, not 24/7. It was operating from 8 a.m. to 8 p.m. So it was closed during the night, but a minor injuries unit only throughout the day. Sorry for the mistake. So yeah, this has, as I've said, been quite a saga. There's been lots of attention from campaign groups and worries as well from the town's MP that this unit might be downgraded further from the nurse-led service during the night in the future. And it seems as though, temporarily at least, that has happened. Now, going forward, the trust has always insisted that this has been a temporary measure for kind of COVID triaging and cohorting reasons. But the suspicion there is that this is going to be a precursor for a permanent move, and we'll wait and see soon. I would suspect whether that is the case. And it was linked to a major incident by some campaigners, which happened earlier this month. A major incident was declared at Gloucestershire Royal A&E, which has taken on Cheltenham's work essentially.
Is that because it had too much to cope with? Was it just too busy?
Yeah, the trust say it was the effects of the current heat wave coupled with increased demand across the whole system. We've spoken to leaders in who have said that maybe it was the 111 pressures which have kind of caused this, i.e., 111 sending too many people to that A&E department. Obviously, the campaigners have linked it to the A&E closing in Cheltenham. But in response to that, the Trust have said since the temporary measures were made, the 4-hour standard at Gloucestershire Royal A&E actually improved, and they were confident that their temporary changes they made services a lot safer.
Interesting. Yeah. So perhaps a bit of a signal that those temporary measures might end up being permanent if the trusts are sort of suggesting it's better for performance.
Yes, indeed. I mean, it was only last year that the campaign group did threaten to take the trust to High Court over what they said was a lack of consultation about moving emergency general surgery from Cheltenham General to GRH. The plan was later withdrawn, so that kind of goes alongside James's points about lack of consultation.
Absolutely, yeah. So thank you, Matt. I think that actually really nicely kind of illustrates some of the sort of local chaos that can kind of be the outcome of some of these kind of temporary changes and tapping into already existing kind of tensions. Thank you both so much for today's podcast. It's time to draw it to a close this week. And as ever, thank you to all our listeners for tuning in. We're back every week. Please do share and subscribe. You can listen to us on the hsj.co.uk website and across all main podcast channels. And we'll see you next week. Goodbye.